Thank you very much. Good morning, everyone, and my thanks to Ash for allowing us the opportunity to present these results to you all today. So, acute lymphoblastic leukemia, or ALL, is the most common cancer that we see in children, and fortunately, cure rates for children with ALL have dramatically improved in the last several decades, with even the last 10 years seeing further improvements. At the same time, I think we are all increasingly aware that health disparities are major issues for racial, ethnic, and socioeconomically disadvantaged groups. There's increasing recognition of not just ethnicity, but also of race as a social as opposed to a biologic construct. However you define the construct of race, there is, however, evidence in childhood ALL that certain biologic prognosticators, like high-risk leukemia genetics, are differentially distributed across the racial and ethnic categories. So with all that in mind, our objective was to examine whether disparities by race, ethnicity, and socioeconomic status continue to exist in a contemporaneous cohort of children with ALL, and if these disparities do exist, whether they could be explained by differences in disease characteristics. So to do so, we used data from the Children's Oncology Group, or COG. COG is the largest cooperative trials group for children with cancer in the world. And we assembled a cohort of all patients treated on COG frontline ALL trials over a 15-year period. We then defined three main concepts: race, ethnicity, socioeconomic status, and disease prognosticators. Race ethnicity was categorized in the way that you can see on the slide. The only socioeconomic status proxy available to us on all patients was insurance status, U.S. Medicaid versus U.S. Other, mainly comprising patients with private insurance, versus non-U.S. patients, mainly jurisdictions with universal health care. Disease prognosticators are the traditional ones in childhood ALL that you can see on screen here. So our cohort was quite large, comprised almost 25,000 children, adolescents, and young adults with ALL. You can see the distribution of race, ethnicity, and SES there. The majority of patients were categorized as non-Hispanic white patients. And unfortunately, we did see substantial disparities in outcomes. So this is a 5-year event-free survival, which is essentially what we think of as cure in childhood ALL. And you can see that while non-Hispanic white and non-Hispanic Asian children had the highest outcomes, the inferior outcomes were experienced by Hispanic children, non-Hispanic Black children, and the remaining racial categories, which for reasons of sample size, we had to collapse down into non-Hispanic. We also saw disparities in socioeconomic status. So we now know that these disparities exist. The next step was to see, can we explain these either partially or fully by differences in disease characteristics or other factors? So these are regression models. It's just another way of illustrating the previous data, showing the magnitude of increased risk experienced by some of these groups. So for example, this slide is telling you that Hispanic children relative to non-Hispanic white children experienced a 37% increased risk in the hazard of an event like relapse. So what we did then is adjust sequentially for disease prognosticators, socioeconomic status, or both to see what happens to that magnitude of risk. And you can see that we actually saw two relatively different patterns. For Hispanic children, the increased risk was partially attenuated when you adjusted for socioeconomic status, disease prognosticators, or both, decreasing from a 37% increased risk to a still substantial but smaller, around 10% increased in risk. In contrast, the increased risk experienced by non-Hispanic Black children was only minimally attenuated by adjusting for disease prognosticators or socioeconomic status, as you can see here. So our key points: substantial disparities, unfortunately, in outcomes persist by race, ethnicity, and socioeconomic status in the modern era of ALL treatment. These disparities are not fully explained by differences in leukemia characteristics, and that the mechanisms underlying these disparities may well vary between specific disadvantaged groups. So it is possible that we didn't fully account for things like disease prognosticators. What we call residual confounding may exist, but that seems unlikely to fully explain the magnitude of the disparities that we're still seeing. So that leaves more uncomfortable mechanisms to consider, things like differential access to care, differential quality of care, and whether you use a now somewhat politically charged term like structural racism or another term, the possibility that even our pediatric oncology healthcare systems are delivering systematically different care to patients across racial, ethnic, and socioeconomic groups. Whatever they are, it is crucial that these mechanisms be elucidated and that interventions be designed and evaluated. And at COG, our ALL committee is establishing a task force that aims to accomplish the above. And of course, having the appropriate expertise and representation in all of these discussions will be key. I'd like to thank all of the study co-authors, our funding sources, and most of all the patients and families that participated in these trials. I'm looking forward to questions.